Genetic information is, of course, critical, but also integral is establishing a relationship between the counselor and the patient. I highlighted patient autonomy because today, as in my everyday practice, I do discuss difficult topics that people have very varying opinions about. And I just want to be clear that just because I am describing something, it doesn't mean that I necessarily advocate that a particular patient should make that decision or take that approach. And if for some reason it doesn't feel clear during my talk, I hope that you'll ask about that in the question and answer session as well. We all respect for patients is a huge component of genetic counseling because we do believe that patients are resilient and know that patients are resilient, and the emotional state that they're in when they're making decisions is also critical. So a little bit of basic genetics. Our bodies are made up of cells, and every cell in the body, just about every cell in the body, contains genetic information. And that information is packaged onto chromosomes. We have about 30,000 different genes that are coded through DNA. A mutation, or also known as a variant, is a permanent difference in a DNA sequence. So those are just kind of some terms. We have about 30,000 genes in our bodies, in each of our cells, and each of those genes directs the body to do something, to create a protein that may direct growth and development, or the day-to-day functioning of our bodies, or our physical characteristics. So as I mentioned, a mutation is a permanent difference in a DNA sequence, but not all mutations cause disease. So there are some mutations that result in differences in our physical characteristics, our hair color, eye color, skin color, widow's peaks, cleft chins, freckles, things like that, skin, and generally skin pigmentation, eye color. And not all genetic disease is caused by a DNA sequence variation. So in this case, this photo on the right, you see we've got 23 pairs of chromosomes. 22 are the same between men and women, and then the 23rd pair is the sex chromosome, and men have one X and one Y, and women would have two X's. People who with Down syndrome or trisomy 21 have an entire extra chromosome, number 21. So that would be an example of a genetic condition that wasn't caused by a DNA mutation, but actually an entire extra chromosome. Is well known to this group. Cystic fibrosis is caused by having variants or mutations in the particular gene CFTR, which is located on chromosome number 7. Variants or mutations in CFTR will impact the manufacture or the function of the CFTR protein, which is a salt or in particular chloride pump that takes chloride inside the cell to out of the cell. So DNA is housed in the nucleus of the cell, and instructions for creating the CFTR protein are read and then go through a very sophisticated manufacturing process and then are transported to what we call the apical cell membrane, or the top of the cell. Over 2,000 different genetic variants have been identified in CFTR. Not even 400 yet have been clearly characterized as causing disease. And that information, just so you know, is from the CFTR2 database. And if you haven't had a chance to take a look at that, it's a really wonderful resource. Some CFTR variants are found to have varying clinical consequences. Some people who have that variant will have CF if they have a second CFTR variant that is known to be disease causing. And some variants are often not associated with the full picture, clinical picture of CF, but might be associated with what we call CFTR related disorders. In males, absence of the vas deferens, pancreatitis, or chronic sinusitis are some examples. So when we think about the inheritance of cystic fibrosis, 1 in 4 does come to mind, and that is really the inheritance pattern for your parents. So when a father and mother are both carriers of one disease-causing cystic fibrosis variant, there are 4 possibilities for their children. So when both the sperm and the egg contain a working copy of that CFTR gene, the child will not be affected with CF and will not be a carrier. If either the father's sperm or the mother's egg contain the working copy, and then the opposite parent has the copy with the mutation, the child would be a carrier and then again not have cystic fibrosis. And then the fourth possibility is that both the egg and the sperm contain copies of CFTR that have a mutation, and the child would have CF. And that's where we get that classic 1 in 4 chance, 25% chance that both the egg and the sperm would contain the copy of CFTR with the mutation. When that child with CF grows up to be a woman with CF, the way we talk about the likelihood of her children having CF in turn is actually dependent on the carrier, more dependent on the carrier status of her partner. So in this case, the partner is not a carrier, and I'm saying truly not a CF carrier. I'm going to talk about some of the caveats of that statement in a few slides down. But when a woman has CF and her partner is not a carrier, then their children would inherit one of her 2 CFTR mutations, and from their father would inherit one of his 2 working copies of the CF gene, which means that all children would be expected to be CF carriers and none would be expected to have cystic fibrosis. When a woman with CF's partner is a carrier of CF, then the chances of having a child with CF become 50%. They'll always inherit one of mom's 2 CF mutations, and from dad, they would have a 50-50 chance of inheriting the working copy and being a carrier, or inheriting the copy with the mutation and having cystic fibrosis. And those percentages are for each pregnancy. So just like with 2 parents who are carriers, in this case, all the children could have CF. All the children could be carriers, or there could be a mix. It's a 50% chance for each pregnancy. And so there are options. When a partner of a woman with CF is a carrier, there is a pre-implantation diagnosis that would need to be utilized with in vitro fertilization. And in my 30 minutes, I don't think I will have time to do a deep dive into risks, benefits, and limitations of IVF, but we can either suggest another expert, or I can come back another time. But what the pre-implantation genetic diagnosis does is fertilize the egg in a dish, grow the embryo up to about 5 to 8 cells, remove one of the cells for testing, and then potentially only implant the embryos that did not have the 2 variants, the father's and the mother's CFTR variants. There's also an option for donor egg or donor sperm, and those can be utilized obviously with or without surrogacy. There are several options for prenatal diagnosis if this is either learned after a couple already conceives, or if this is how they choose to proceed. There's chorionic villus sampling, which is performed at about 10 to 12 weeks, or amniocentesis, which is usually over 15 weeks, and both involve sampling some of the cells of the developing pregnancy. In the amniocentesis, it's a needle that removes some of the amniotic fluid, and in the chorionic villus sampling, it biopsies a little piece of the developing placenta. Both of these procedures do have a risk of miscarriage, and then if the fetus, the baby, is found to have 2 CFTR changes, then the couple would make some decisions about whether or not to continue the pregnancy. Also, on the available options for when the partner is a carrier include having sonograms to monitor for meconium ileus, and these can be done whether or not prenatal diagnosis is performed. Knowing that a baby is expected with CF and is going to have meconium ileus is going to change the birth plan. You're going to bring in a lot of extra support, make sure that there's a surgeon on call, that the neonatologist is not on vacation, that your favorite OB is going to be there to manage your delivery. So all those factors can fall into place when we're planning for a baby who's going to be born with meconium ileus. There's also, in all 50 US states, there is CF newborn screening. The screen, again, that's a whole other talk, which again, I'm happy to give at some point. CF newborn screening, though, involves several components, and the first step is a is a chemical screen called immunoreactive trypsinogen. And when you're expecting a baby with CF, or there's a baby who's at 1 in 2, has a 1 in 2 chance of having CF, the recommendation would be to go directly to the DNA component of the newborn screen. And that usually, again, involves some planning, and that can be done. And then the other recommendation is to do a sweat test after the baby is born. And all of these all these slides are an option if the partner even doesn't have testing. So I just want to make sure that that is on the table, that not every partner of every woman with CF has to have carrier testing. It is something, though, that you can consider together. So the likelihood that the partner of a woman with CF would be a CF carrier really depends on their family history, but also their ethnicity. And you can see here that in the Ashkenazi Jewish and the sort of European Caucasian populations have the highest frequency of CF carriers, and as ancestry kind of moves away from European, the likelihood of being a carrier decreases as well. But also the detection rate for carrier screening is ethnicity dependent, and as you notice, is not 100%. And you have choices about what kinds of genetic screening panels for CFTR that you can utilize. The common recommended screening panel, every single panel that is offered in the United States needs to have at a minimum 23 CFTR variants. And of course, that includes the most common one, the Delta F508, which most people who are going to be carriers of CF will be positive for Delta F508. About 70%. And then the other 22 variants are much less common. Some are a little bit more in certain populations. There's a mutation W1282X that's more common in the Ashkenazi Jewish population than Delta F508 is. But the 23 is considered to be a fairly multi-ethnic panel and picks up about 85% of carriers in a general US population. Some laboratories offer expanded mutation panels. There's a very highly utilized one that tests for 97 mutations, but they can go up to 400 plus CFTR variants. And then the other option is to do gene scanning or sequencing, two different techniques that kind of accomplish the same goal, to look at all the up and down the CF gene, to look at the coding areas of the gene, to look for variants in CFTR that would definitely or might likely have clinical consequence, and report those. And then there's an extra test called deletion duplication that looks for a more rare type of mutation that is not easily picked up through standard sequencing. Because there's no test that is 100%, as I started to mention a slide or two ago, the detection rate for the Ashkenazi Jewish population is one of the higher rates, and that's because it's a fairly small cohesive population, and only a handful of mutations, about 6 of those first 23, are actually common in the Ashkenazi Jewish population. And both the likelihood of being a carrier and the detection rates decrease as you move away from European ancestry. The likelihood of still being a carrier of a mutation that was missed by the screen is then dependent on a statistical analysis of your initial risk and the detection rate. And then the likelihood of actually having a baby with CF for a woman with CF and her partner after a negative carrier test would be about half the partner's residual risk. So for a non-Hispanic white male and his partner, the chances would be 1 in 400 to have a baby with CF after he's had a negative test. When the 23 mutation panel is used, let me just be really clear about that. When you do sequencing, you can increase that detection rate for any ethnic group up to probably 97, 98%. Again, we're not at that 100% rate, and adding then that would include some deletion duplication testing as well, but we don't get to 100 when we add the deletion duplication. So then there's a question, should everybody have CFDR screening using the sequencing technology? And that's really a decision that needs to be made individually. The costs are coming down, and more laboratories who do sequencing are contracting with insurance companies. So, a couple of years ago, I would have had as a limitation about how expensive it was, $2,000, $3,000, $4,000. There are laboratories that will do this now for $199 out of pocket. So that is kind of a little bit off the table. The benefits of sequencing is that it will find rare disease-causing variants that if you use just a panel of known variants, that may not be picked up. So those family-specific mutations or ones that just haven't been well described yet in the literature. And it can provide some additional reassurance if the test is negative. Varying clinical consequence. And so the counseling that happens after that's detected can be very challenging as couples kind of grapple with what to do with that information during a generally stressful time when you're a pregnancy, when you should just be really looking forward to having your baby. As I mentioned, sequencing still doesn't detect all variants. And in fact, a lot of prenatal laboratories will not report those variants of unknown significance in the prenatal setting. So those are all issues that we manage both by helping patients and partners understand the limitations of the testing and then make the most informed decisions for themselves. Just a little note here, though, that people with CF who don't have identified variants and haven't had sequencing with deletion duplication should go ahead and do that. As we have more and more personalized medicine options for people with CF through genetic modulators and just the opportunity to potentially participate in clinical trials, we would recommend a full sequencing to try to find those variants. And the other reason to go ahead and have genetic testing if you have CF and you don't know your variants is that it is helpful to your relatives. Again, I'm returning us back to that 1 in 4 diagram for your parents, 2 parents who are both carriers. But when we look at the chances for the siblings to be carriers themselves, it's not 50%, it's actually 2/3 because we know that they don't have CF. So there are 3 possibilities left. So there would be 2/3 chance that they are a carrier and a 1/3 chance that they're not. For your relatives, your siblings, aunts, uncles, all have an increased chance to be carriers. I mentioned the 2/3 for the sibling, but for an aunt or uncle, the chance is 50% and 25% for the first cousin. And providing access to your CFTR mutation results helps them make sure that the laboratory panel that they're using includes the family mutation, because if it doesn't, then their negative result really isn't interpretable. You don't know, were they negative because they're not a carrier of the family mutation, or are they negative because we didn't pick the right test to get to identify that family mutation? If a person with CF is in that 1 to 2% of people who have truly unidentifiable mutations using all the technology that's available to us today, partners of your relatives can be tested first, and that will help to determine what the overall likelihood is for them to have a baby with CF, and then we can move towards some other more sophisticated and a little bit arcane, though, testing that's available for rare mutations in a prenatal carrier screening setting. As my take-home messages, negative DNA screening reduces the chance for a person to be affected with CF, or if they're in a diagnostic setting, or being a CF carrier, but does not eliminate it 100%. We know some variants in CFTR will be missed, if all known methods are used to try to find them. Some of the variants don't have a real clear-cut interpretation right now, and those variable mutations may not even be reported as a positive carrier screening result. And as I mentioned, your relatives would benefit from having access to your CF variants in order to be able to interpret their results accurately if they're negative. So I'm going to kind of move on to genetic counseling issues beyond partner screening. We know, and I know you've had some really wonderful speakers with this group already, that women with CF can conceive and have healthy children. And so I spend a lot of my time talking about risks, but I want to make sure that I bring it back to the likelihood. The greatest likelihood is that your partners are not carriers of CFdr variant. So the greatest likelihood is that your partners are not CF carriers, and that if you do choose to become pregnant, that you will be able to deliver a healthy baby and have a healthy pregnancy. But there are some steps that we do take to try to maximize the likelihood of those things happening for you. Talked a lot already about partner screening. There are just some basic prenatal and preconception strategies, like taking folic acid and prenatal vitamins preconceptionally, making sure your vaccinations are up to date. And then I'm going to talk for my last few minutes on a few other things. The CF-related diabetes control, review of medications that we recommend preconceptionally, and also just general population screening recommendations beyond cystic fibrosis. And then I think that will take us into our Q&A. There's a pretty high percentage of women with CF who have CF-related diabetes, and diabetes in general is a common comorbidity in pregnancy, both in and out of CF, and we do know that poor diabetic control will increase the risk for delivery complications and the need for C-section, and it does increase the risk for birth defects if women have poor glucose control, especially in the early stages of the pregnancy, but throughout. Women with CF-related diabetes do have higher rates of C-section, and they're a trend that was identified by Raynaud et al., more often needing assisted conception. We recommend that there's good diabetic control for at least 3 months prior to conception. Obviously, we want you to have good diabetic control all the time, but for our women who are considering conception, we do want to make sure that is first and foremost. One of the things I do as a genetic counselor when Dr. Walker's patients are starting to think about conceiving, we do look at the medications that our patients are on. There is not really a straightforward recipe for saying you must get off of all medications versus these are always bad, these are always okay. Always have to weigh the potential health benefits that the medications provide for the mother, because we know that the way to maximize the likelihood that you will have a good and healthy pregnancy outcome is to keep you healthy throughout the pregnancy. That the placenta does a very good job of filtering a lot of things the baby doesn't need from mom's blood. And so we kind of weigh those risks and benefits. We do look at the literature. I have a database called Reprotox to look to see if there's an increased risk that's been identified for birth defects above that 2 to 3% general baseline risk for birth defects. Everybody has a chance to have a baby with some type of physical problem at birth. Again, that translates to 97, 98% of babies are not born with any kind of physical problem at birth. But is there any increased risk as a result of exposure if a pregnancy is exposed to that medication or to that substance? And what's the nature of that risk? Is it really evidence-based? Do we really know that those two things are causing each other? Or is it based on single case reports? And when one of the classic statistical case studies is murder rates go up in the summer and ice cream consumption goes up in the summer. Does ice cream consumption cause murder? No, it does not. So we want to make sure that when we see two things, are they really related to each other or are they coincidental? We also consider how far along the pregnancy is at the time that the medication is needed. There are some medications that maybe shouldn't be taken during the first trimester when the baby's organs are really developing, but they aren't. There's not such a risk of a problem later in the pregnancy. So we time those kinds of decisions as well. We also look very carefully at the potential harmful effects, especially to the mom, but also to the pregnancy, if a medication was either discontinued or if there wasn't a really good alternative that might have a better safety profile. One of the challenges of doing these medication is that knowing how these different medications may react to each other and how the combination of those medications might affect the development of a pregnancy cannot always be quantified or assessed. And one other issue that we always look at, especially with things like vitamins, is that the absorption issues that women with CF who have pancreatic insufficiency may make that assessment different. Like, for example, if you're not absorbing all of the vitamins, then we worry a little bit less about having a teratogenic, which we call, or a harmful effect on a fetus. That would be one example. Like vitamin A is associated with a drug called Accutane, which is known to cause birth defects. We would never put any woman on Accutane while she was pregnant, but now we have to think about vitamin A, for example. And those conversations are really very individualized between the patient, the CF team, and the OBGYN. And those, now with modulators, we have more things to think about and less of a likely scenario where we'll have good case controlled studies that will give us the data that we need to figure out whether people should stay on or come off these drugs when they're pregnant or thinking about planning a pregnancy. So here's some resources for you. I think Laura has uploaded this first document called Genetic Counseling in the CF Care Center to the CFReSH site, and if not, I'm sure it will be up shortly. NSGC.org is a way to find a local genetic counselor by zip code, and you can also look at his or her specialty. If there's not a specific note about cystic fibrosis interests or specialization, just general pediatrics, adults, neurology, those might also have some overlap with enable you to find a genetic counselor who is interested in working with women with CF. And then, as I mentioned earlier, the www.cftr2.org, which will give you information about the different CFTR variants, which ones have been identified as disease-causing, which ones have varying clinical consequence, and then what is known about not only a particular mutation, but also how they work in combination when there are enough patients in the database to provide that information. And the data from CFTR2 comes from the CFF patient registry. So every couple of years, they have a big data dump, and they do a very sophisticated analysis to try to update patients, families, and researchers about the different mutations. So I just want to, I spoke faster than I thought I would, but I guess I shouldn't be too surprised about that. Thank you. I want to thank my team, my patients, my families, and to CFReSH for giving me this great opportunity to talk with you today.